Hello everyone, I'm so glad today to have a new episode of the podcast series Connecting Social Research to Society. I'm with you, Sari Hanafi, Professor of Sociology at the American University of Beirut and the founder of the portal for social impact of scientific research in/on the Arab world called Athar. So today I'm so glad to have a friend, a colleague from American University of Beirut, Tania Bosqui. Hello, Tania.
Hello, thank you for having me.
Pleasure. Tania Bosqui is a British-French clinical psychologist and associate professor at the Department of Psychology, as I said, at AUB, American University of Beirut, with over 10 years of clinical research experience. She's also clinical supervisor for the hospital of our university and a very interesting non-governmental organization, NGO, called Embrace Clinical Psychology. Embrace, okay? So she is working in clinical psychology training programs inside of this organization. We'll talk about it at a certain point. Also, she is an adjunct professor at Trinity College Dublin, Center for Global Health. Bosqui holds a doctorate in clinical psychology from Queens University Belfast and has taught previously at the University of Guam, Trinity College Dublin and University of Siena. She has also completed postdoctoral research fellowships at the Center for Public Health and the Institute of Child Care Research at Queens University Belfast. She conducted research in different topics, but really with a strong focus on family intervention for at-risk adolescents in Lebanon, health problem related to Syrian refugee children, particularly mental health, but also about psychosocial interventions in Palestine. She also did field work in Guam, in US, in Finland, and in other places. Again, hello, Tania.
Hello. Yeah, Thank you for the introduction.
Yeah, pleasure. So, why did you go to psychology?
Psychology and clinical psychology were two different things. So firstly, for psychology, I came from a family, as many psychologists have this kind of history that makes them interested in psychology. It was very personal. So I came from a family, very disjointed, lots of broken family, multiple broken families with lots of mental health difficulties and even suicide in my family. So I was always exposed to distress and I saw the failures of the system, both in France and in the UK, in supporting families with these difficult socioeconomic difficulties, family difficulties, mental health difficulties, suicide prevention and grief. And so I always was in the back of my mind interested. So I studied it at school and I had a wonderful professor who was really at A level, who was really encouraging of me to continue at university and was lucky to live.
This is really, I would like to stop here. You did this in UK. So in the high school, you take a class of psychology.
Yes.
This is not the case in the Arab world, by the way.
No, I was very lucky. I mean, there are pluses and minuses, but at A level, so at 16 years old, you already specialize in 3 or 4 topics. And psychology is one of those.
Okay.
In other contexts, maybe it's a bit young to be making those decisions, and others, make that decision at 18. But in the UK, it's at 16, and so I was drawn to psychology, and then had this really wonderful teacher who really encouraged me to continue my interest in psychology.
So you have a straightforward formation, a BA, a master?
Well, I did a master's in a different topic.
Okay.
So this is why I'm saying clinical psychology, because I saw this mismatch between what services were doing and the reality that I was seeing at home, and that when I started working, and I was working as a support worker, minimum wage, working with people who just got out of hospital, from psychiatric hospitals, out of prisons, and I just saw the failures of the system, because they really had no chance in changing their lives, and would either end up back in hospital or in prison or worse. So I saw this mismatch, and I was very frustrated by psychology and the failures of the system, and I was also very interested in getting outside of my small world in the UK and traveling, and so I did some work abroad in India and Mexico, Uganda, and I traveled around kind of volunteering or working for different organizations and in a kind of psychosocial capacity. And then studied international development, and thought that I would go off in that route. But because I had this kind of mental health background plus the international development, I brought it together in my thesis, and there was very little at that time. There was no such thing as global mental health. And so I became really interested in improving psychology for this wider context of injustice and unfairness and systems, collective thinking that just didn't exist at that time in psychology. So then I did clinical psychology.
And it's true from your research. It's clear you are always interested in area in conflict. I mean, whether forced displacement or after a crisis. I mean, Lebanese uprising in October 2019, or the blast, or So my, if you like, while I'm writing my book against symbolic liberalism, a plea for dialogical sociology, I was interested in, if you like, scholars like Eva Illouz working on emotional capitalism and somehow criticizing positive psychology, for instance. I mean, one of the arguments, I mean, there is two arguments that we need to reflect why people go to psychologists in, I mean, the rate of those who go, the growth and the preponderant, if you like, rate in some Western countries. I mean, not to generalize. It's definitely not in Lebanon. It's definitely not in Syria, a country I know, or Egypt, etc. So if you like, this is one phenomenon, and the other phenomenon is that it's commodified more and more, and at the expense of family intervention. So if you like, some of the criticism, if I want really to put it in a simplistic way, is to say, look, usually Tania has a problem. She goes talk with her elderly sister or her mother or her father, and even if there is a problem with the authority of father, for instance, that you and your mother will try, your mother will try to go to talk with your father to modify his behavior. So if you like, you have a kind of the social relationship, the family can resolve some problem that psychologists would be more difficult, if you like. So if you like, there is this kind of criticism that it goes with this excessive individualistic society we live on, and suddenly looking to your work, Tania, you are interested in many articles in family intervention. Are you conscious that you are a counter? Do you agree of the criticism I talk about? So, but
thank you. Yes, I do agree generally. There's a lot of evidence for the effectiveness of a lot of individually focused interventions. So it's not that I'm completely against any form of individual intervention, but I think there's an over-focus and a complete neglect of other types of interventions and of support mechanisms, and that is harmful for the mental health of people, and it reduces access to mental health care because it doesn't always fit with the assumptions of the people who need help. And so there was a beautiful paper while I was studying in the UK and working as a assistant psychologist. There was a paper written called Beck Never Lived in Birmingham. I was living in Birmingham, inner city Birmingham at the time. There's a lot of gun crime, a lot of drug abuse, a lot of major issues that we were seeing in mental health services. And these colleagues wrote this paper exactly as you're saying, to say, but these types of interventions don't fit in this context. Beck being Aaron Beck, the founder of cognitive behavioral therapy. So they were criticizing this over-focus on the individual that neglects entirely the context in which people are living, and that many of the experiences that people have are a normal reaction to an abnormal society in which there's injustice and oppression and harm happening within a family, within a community, within a neighborhood, within a country. And so I was very interested in exploring that further, not just in terms of being critical, which I have been very critical in my writing of the tendency to focus on the individual without context, but also to find out, well, okay, so if we accept that criticism to be true, what else can we do? How can we make mental health care more collective? How can we address the systems around an individual who is suffering? And so family work really came into that concept that a family is there all the time, functional or not functional, they're there. And they may also have been suffering, and they may have been suffering for generations. An individual does not live in a vacuum. And so if we can support the family environment or the peers or the spouse or whoever is in that person's environment day to day, then we can better support the individual.
Yeah,
so that's where that idea came from.
So the idea first is a kind of integrated solution. So you look to poverty of the family in order to think about how to improve the mental health, etc. But also if there is really even if there is a mental health related to psychological issues, you intervene the family. So if you as a practitioner notice that the client, the individual, complain about the family, how would you do?
It depends on the service, but usually many services cater to individuals. So an individual accesses a service either for themselves or for their child. And so they become, if you want, the identified patient. They're the person who is seen to have the problem. But often that person is just a mouthpiece to a wider problem, a problem that's happening in the country, the economic collapse. We saw a huge spike in mental health problems. Of course, people are suffering because of the context. Or within the family, there's marital discord, or there's abuse, or there's other problems. And so I wouldn't automatically assume that the person who is identified as the problem is the actual problem that needs to be treated. There may be many other problems that are usually systemic, circular, and macro.
So it means even if somebody identified as a problem as a family, at certain point maybe we can bring the family and in the fore, no?
Yes, and often I would say it's the majority of cases that I see in Lebanon and elsewhere. There is some work to be done within the family system, and that's not to blame the family. It's just that it's more complicated. Human psyches are more complicated than just an individual having a cognitive distortion or a behavioral problem, or it's just so much more complex. And so either in terms of addressing the problems or even just to support the solutions, family are really key. And they're even more key here because people really value families and are very much connected to their families for much longer and in a more closer way than in other cultures. So it's so vital for families to be part of the solutions and of the support.
So for instance, you train on family systematic intervention model, for instance, in a program called Sawa Aqwa. Sawa Aqwa, which is a translation of Together Stronger family program. And I think there is an organization called, or a program called like this, no?
There is.
International. I mean, not only...
We developed it in Lebanon. The idea was to develop something. We got funding to develop an intervention based on this criticism into the humanitarian interventions that are being currently delivered in humanitarian contexts to refugees or to others affected by major adversities are focused on the individual, and we know that they are very much affected by their environment, that it's not an individual problem, it's a normal reaction to an abnormal circumstance, and so strengthening the family functioning around children could improve their mental health. That was our hypothesis, and so we developed this Sawa Aqwa here in Lebanon to be contextually grounded. We used evidence from outside, but we worked predominantly with young people and their parents to develop this content, this theory of change, and an 6-session intervention that could be delivered through child protection mechanisms in Lebanon. So it was developed in Lebanon, and then it was also tested in Jordan and in Iraq.
Okay. So really very interesting. So and you did the work with the Syrian refugees here. So what kind of work?
Yes, many different studies with Syrian refugees, also with Palestinian refugees, and later after the economic crisis, also with low-income Lebanese families who are also really struggling. But when I first came to Lebanon, I was working on an intervention called the Common Elements Treatment Approach. It was developed by Johns Hopkins, so it's very much a kind of external intervention, but it's evidence-based, cognitive behavioral focused. It has some parent component, but predominantly individually focused. And we did an RCT, and we adapted it for telephone delivery just before COVID, so it became very useful. And so that was targeting Syrian refugee children aged 8 to 17 in order to improve access. The idea was that Syrian refugees at that time had very little access to get to the nearest mental health clinic. They had to travel, miles and miles with very little resources, with other children at home, and so the idea was to deliver this through the telephone.
And when we talk about mental health, particularly
it was targeting depression, so it was transdiagnostic, so this is a whole other conversation we can have about diagnosis, but it was depression, anxiety, trauma and behavioral difficulties. We also had a substance use component, but we didn't really, I don't think we ever used that. So it was really focused on anxiety, depression, trauma and behavioral difficulties, and we kept that quite broad. I also wrote a paper about the experience of that because we were validating some measures and in context, and just finding major contextual differences in how this so-called diagnosis was presenting and could be administered or overused because of just socioeconomic challenges. So to give you an example, we were often flagging conduct disorder, which is a very severe behavioral disorder in childhood, and it's related to violating massive social norms. But it was being picked up in the questionnaires because the children were not monitored because parents had to work, had to leave their children. They were living in camps, so they had very little to do, and they were not in school because they were not allowed to access school. Many were undocumented. And so not being able to go anywhere, and so there were things like fighting, and there were things like throwing stones at cats, and they were just kids who were really had nothing else going on, and no supervision and no stimulation, and so these were completely normal behaviors in that context, but they were being labeled as having a conduct disorder. And so we wrote a paper really critical of using this type of diagnosis in this context.
And this is somehow in continuation of your work you did in Finland, where my feeling you go against the over medicalization of some mental health illness.
So the work in Northern Ireland and in Finland, we replicated it in Finland, but it started in Northern Ireland, and on the neighbourhood context and how that affects individual mental health, and that we give these diagnoses as if that context doesn't exist. So we found in Northern Ireland, for example, that and given the sectarian context there, that Catholic people in highly sectarian neighbourhoods had worse mental health than Protestants in highly Protestant neighbourhoods, very much related to the sectarian context, injustices, oppression, and exposure to that in some neighbourhoods versus others. And so this is not an individual problem. And at that time, we were not talking about anxiety and depression and what we would call common mental disorders. We were talking about psychosis. This was first episode psychosis, schizophrenia. And so these are really severe and enduring mental illnesses. Very extreme symptoms, can be highly distressing, and we're finding that there is a significant neighbourhood effect on the prevalence. So this is not an individual. We very much think of this as a brain problem. It's a chemical imbalance, but it really has a major contextual component.
And if you like, the work of Rita Jacoman about the problem of how we see the post-trauma syndrome as if the shock or the trauma is we can identify it with an event and not in a process. And I saw one of your publication entitled Clinical Psychology Without Borders, Psychosocial Interventions in the Occupied Palestinian Territories. So are you making the same kind of argument, for instance?
I very much support her work, yes, and also that of Dr. Jabber, who has written a lot about the use of in inverted commas, traumatic stress disorder, and how that doesn't apply to the context of Palestine when it's intergenerational, transgenerational oppression and injustice, and that we cannot use a diagnostic criteria. It just doesn't make sense. So I very much support that, and I'm very grateful to the colleagues that I worked with, Dr. Fatih Fleffel and Dr. Bassam Moshoud, who I worked with in the Psychosocial department in the Red Crescent in Palestine, and really opened my eyes to that problem that I'd already been I'd already started to think about that in the context of poverty in Birmingham, in the context of conflict in Northern Ireland and the legacy of the Troubles, where I did my doctoral training, and then I saw the reality of that in a much more visceral way in Palestine.
You wrote this in 2014. I was earlier in Palestine from almost 1999 to 2004, and where so I was intermingling with some French network. Among them is Médecins Sans Frontières, and Médecins du Monde, and Médecins Sans Frontières. Both they were there, but I discovered Médecins Sans Frontières, they have even if you like, you have in the facade a Palestinian or a French doctor, but the consultant who tell them how to see the big picture are Israelis. And I'm not saying really that necessarily is if you like a colonial Israelis, but the very idea that you you insist in the context. I mean, you need to contextualize. So it's better to bring Palestinian to understand that.
Absolutely. And I mean, we saw it happen everywhere. It happened also in Northern Ireland, that we would have British from England coming, psychiatrists, psychologists coming to provide services in the context of Northern Ireland, particularly for Catholic Northern Irish people, and that was they just could not understand the context. And so they're giving labels, giving medication, giving treatment where there's a mismatch between the reality and their experience, and I think that happens too in Palestine. I'm sorry to hear that about MSF, because I'm sure they don't do that now, but that's disappointing, because of course the understanding of the context is completely different, and we cannot treat people in a vacuum.
Absolutely. Yeah. So Tania, you have a paper about Lebanon, where you look the need. This is a title: the need to shift to a contextualized and collective mental health paradigm, learning from crises hit Lebanon. So
it's my favorite paper.
yeah, and one of the
I really enjoyed writing it. It was a rant.
Rare paper where you write it solo, and we will come about this issue of solo versus co-authoring. Yeah. So what is in what should be really? I mean, first you talk about collective.
Yes.
So is it a continuation of a family? So what is?
Yeah, it goes beyond family. And actually, now we're working on a community version of the family that intervention, the Sawa Ahwa, to see, can we build something that strengthens a community around children as well, not just within the family, because of the recognition of the collective, the importance of the collective. And there was some research done in Lebanon in the 2006 war that found really a strong link between what was happening at the collective and what was happening at the individual mental health level. So we have evidence that it's important, but it's not being addressed in interventions. It's not being addressed in the way that we are setting up systems to support distress. And we see it in very low numbers of uptake. I've done some studies on very high pre-treatment dropout in refugees. You can offer evidence-based, free interventions over the phone, no transport, and people don't come. They don't come, even when there's an identified mental health need and an interest. And there's a reason for that. There is a mismatch between the types of interventions that we're offering and the type of need, and the perception, which I believe is a very accurate perception, that this is more than just the individual experience. People are struggling at a collective level. It's collective trauma, it's collective harm.
And maybe something often missing when we conceptualize community is the neighborhood, the neighbors. I mean, الجيرة, in Arabic, al-jar, I mean, really, in Arabic there is a proverb say, الجار قبل الدار. You look for a good neighbor before looking to a good house, if you like. So a good house is a house with a good with a good neighbor.
Yes.
الجار قبل الدار. So and I see, I mean, around me, especially for mothers and female individual. I mean, neighbor is extremely important.
Extremely.
I mean, they become like friends, sometimes intimate friends. The mutual help and
yes, especially with children, this is really vital. Really vital. And what we saw, we did some interviews with families. It was around 2020, so it was around the time of the explosion actually. And we were working predominantly in Tripoli, and we were interviewing people about their communities, who was around to support, who was difficult within their community environment, not just their family environment. And I was astounded. I really expected, with this stereotype that I had of, Lebanon has a strong community, that these families were living in neighborhoods where they, particularly Syrians, but also for others, where there was a lot of hostility between neighbours, lots of arguing, lots of conflict, to the point where families were very insular and having maybe some extended family support, but not within their neighbourhood, not within their street. They were feeling really frightened of their neighbours, and that was very, very bad for parent mental health and for adolescent mental health as well.
Tania, I didn't do, I mean, all my energy and my research went to the to the Palestinian refugees. But I did a small work after I analyzed a big survey among Syrian refugees, and particularly in the Beqa Valley. And it struck me two cases where I spent time with them. These two cases moved from the city Anjar to a refugee camp, a Syrian refugee camp. So what this story is around 2016, if my memory is good. I mean, so when I asked them, so why do they move? Is it because there is more service in the camps? So I said no. Actually, the same organization taking care with us in renting an apartment or being in the camps. However, we suffer from neighbors where when you say good morning, they don't reply. We felt so much isolated. So in the camps, there is a conviviality, and that we don't find it in the city as a refugee. And this is good for they didn't say mental health, for our sanity, for they use a word in Arabic. So really it struck me. I mean that we always we think that if people afford to be outside of the camps is better, but in fact we have cases it's the opposite.
Yes, and it's interesting you say that because we found something very similar. We delivered Sawa Ahwa in Tripoli and in North Bekaa. And we also we were doing an implementation effectiveness trial. And so for the implementation side, we also were testing groups of families. Can we deliver this intervention to groups of families? It's a lower cost, but will it work? And when we did it in we were in Badawi, in an urban setting in Tripoli, there were so many issues of scheduling and confidentiality and, people not feeling comfortable being with these other families. And then in the camps in North Bekaa, it was completely different because people had this sense of community. So there was much more respect towards each other, and it was much smoother to deliver. And so yes, I agree. And the effect of urbanization on mental health has long been found to, there's an association between, when you look at urban versus rural, we found it in Northern Ireland, in Finland, all across the world, you'll see this effect. Mental health is always worse in the urban setting at a population level.
Tania, looking to your research, and if I compare your profile to the Arab psychologists and clinical psychologists that I looked to their CVs during my research on knowledge production in the Arab world, I noticed that often they have a very small, if you like, research team. So looking, for instance, to co-author with whom you co-author. Most of your paper is sometimes reach 10 authors.
Yes.
while in most of the CV I notice is 1, 2, maximum 3. So this is really very interesting. I mean, so do you have? Can you tell us a little bit what the meaning of working in a big research team versus small? What?
It's a really interesting question, and I hadn't really questioned it myself before in terms of why I work more that way than another. I think part of it is just because of the type of research I do. So when like for example, Sawa Ahwa was a very large randomized control trial. We had 3 different partners, and we really needed a lot of people to be involved. And I also, I guess, value having people involved at a co-authorship level. So including, our NGO partners are not academics necessarily, but they inputted a lot in how we design a study, how we implement, and so to make sure that they are part of that publishing process, that it doesn't just get kept within the university. But I also believe in really having this kind of international perspective, having people who have experiences elsewhere who can say, have you thought about this, have you thought about that? And so even when I'm designing the team and inviting people to a particular project, I think about who could really challenge us and that have maybe done this somewhere else and has experience of it, or has done something completely different and might disagree, so that we can have the best final kind of product that is informed by all of those rich experiences from others. So I do go out of my way to include as many people as will agree to to participate or inform the work. That's probably why, but I do think it's partly also, clinical psychology tends to be more, if it's theory driven or it's focused on a particular case or a setting, then it will have a smaller team, whereas my work has tended to be larger trials, and so that lends itself to including more people.
Yeah, and I noticed you do a research by trial, and
Yes.
So can you tell us about that? I mean, is it the best?
Good question. Yes, I mean, many people would say yes. There are many limitations, but in terms of our best way of testing a mental health intervention, in order to disseminate that, scale it up, to be delivered to people who may benefit from that intervention, a randomized controlled trial is the best we have. It's the best methodology we have to be able to answer a question about is this effective? Does it work? And so I have used many randomized control trials to test different interventions where you deliver an intervention having randomized people to either have the intervention or not, and we do a pre-post and follow-up testing using validated psychometric measures. In order to be able to see, is it the intervention that created the change that we're trying to see?
And this is time consuming.
Very time consuming. As a research method. And very expensive.
Yeah. And very expensive. Yeah. So this is why it's often also, I don't find it a lot from my colleague in the report.
Yes, and funding has become more and more difficult. Really
that's true. I mean. Actually, and this is the third act, now it's time to talk about it. I mean, you are also lucky that you are well insert in international organization that is doing specific research, but local Lebanese NGO, I mean, like Embrace.
Yes.
And so so again, the name of this podcast is Connecting Social Research to Society. I mean, how would you see this bridge? I mean, how you will ensure that this beautiful research you are conducting, that it's go to the beneficiaries in some, so can you tell us a little bit, and particularly about Embrace, because really this is a very interesting NGO in Lebanon.
Yes, agreed.
Yes,
and maybe just to start to say that, so although randomized control trials have been, lauded as the sort of gold standard how we test an intervention, there has been a shift because of the recognition that we have all of this evidence for interventions, but they're not being delivered. So what is the point of all these beautiful randomized control trials if we're not scaling up and delivering these interventions to people who could use them? And so implementation science has become a greater focus for what I'm doing now, in order to learn, well, how can we scale up? How can we fund? How can we make this sustainable? How can we integrate it into existing services? And so many of my colleagues and I are really shifting now to, well, how do we make sure that our research, as you say, is used and useful?
So instead of jumping to another research, no, we want to follow up in a certain research, and often the follow up is without publication. So it's not driven as like we say in capitalist society, is money driven. It's not article
it's
driven.
Impact driven.
But it's a societal.
And there is more of an interest in publishing that kind of work now, so we can learn from how did others implement. And that's becoming more acceptable for journals to publish that kind of reflective work or process work, which I'm very glad to see, because that is it's a lot of effort, and we can learn a lot from how others have managed it. And there's some very good examples, including in Lebanon, the National Mental Health Programme tested an intervention called Step by Step, and they have multiple phases that has gone into the point where it becomes, accessible to the entire population online. So there are good examples in Lebanon of implementation, and that's really where.
By whom, by the way?
The National Mental Health Programme is through the Ministry of Public Health.
Okay,
it's WHO funded, I believe, but they are grounded within the ministry. Yes, and then they have working relationships with all of us.
And it's very interesting that you have a union order.
Yes, the Lebanese Order of Psychologists.
It's 2 years, 3 years ago, no?
I think it's now the end of the 3 years.
A clinical psychologist.
Yes, to license psychologists, which is wonderful, because otherwise there's no accountability or governance around who is practicing psychology and are they really qualified to be doing that.
Do you think that one day you will license yourself here?
I would love to, but I would love to, but it's actually not possible as for foreigners to be licensed in Lebanon.
Oh
so they're part of the same rules for
even
doctors,
if
lawyers.
If you have lived here for 10 years.
No, I'm not allowed to apply for a license. So I'm allowed to do clinical supervision, which is what I do at AUBMC and at Embrace, but I'm not allowed to practice here. So that's maybe it will change in the future, but for now, unfortunately, that's the reality.
Unfortunately, I would say even for Palestinian of Lebanon,
I think that's
who was born and fourth generation now being in Lebanon, scandalous, really.
It's not designed for me specifically. It is really designed for Palestinian Syrians, not to work in Lebanon, unfortunately. That's the reality.
So Embrace, it's an organization dealing with an extreme case of sometimes of mental health, suicide.
There's two elements. So they have the Lifeline, which is the first hotline. Now it's 24/7 that people can ring. It's focused on suicide prevention, but is really accessible to anybody in distress. And so that was developed, I think, the year that I arrived in 2017. It had just been launched, and it was the brainchild of Mi Atwe, who's really fantastic psychologist and visionary, really, who was able to establish this incredible initiative, and that it's not only continued but has grown and provided so much mental health support across the country that is more collective because it's more accessible to everyone. It's not saying you need to have this disorder or you need to go to a clinic, or it really is accessible to everyone. So it's a wonderful initiative. But they also have the clinical psychology training program, and they offer also mental health services in general since 2020 after the explosions. So this is when I became involved with them. Through my colleague Pia Zainoun, who's unfortunately now left AUB, but still very much involved in Embrace. And so the clinical psychology training program started after that to train psychologists through Embrace. And through the services, one-to-one services that they were providing. And so I'm a clinical supervisor with them since then.
Okay.
Yeah.
Very good.
And maybe I could just add one thing, as we were talking about implementation science and translating research to findings. So of course it comes through in my everyday way of supervising. Of course, all that research, is disseminated in some way. But I also do didactics with the Embrace training program, and also in our clinical psychology MA here in AUB, where I've integrated research findings. So to give an example, we developed as part of the Sawa Ahwa intervention family competencies, which didn't exist before in the humanitarian sector. They were really only individual or group competencies, and we developed family competencies. Now they've been taken by another collaborating organisation, War Child, and they will be posted on the UNICEF website, the EQUIP website. And so those competencies I've integrated into the training in Embrace and also into our training program in clinical psychology that really focus on building those skills for working with families. So there's a dissemination pathway there. We just need to scale it.
Very interesting. Again, the importance of family intervention in
it is so neglected. We now have a diploma in child and adolescent mental health in the region, and it's with Save the Children. We're in our pilot year, and what we noticed from our baseline data, we've done an evaluation. In our baseline data, we used the different competency tools, and while we were finding, fairly good outcomes for individual and group, when you look at family, people were lost. They just are not trained to work at the family level, even though we know it's so important. We have evidence that it's effective, can improve well-being, can improve mental health, caregiver well-being, and so on. People are just not trained in that way. And so we're really seeing, so we're now addressing that in the diploma specifically. We have a module on working with families and communities in that spirit.
This is excellent. Tania, living here, do you feel that you need some Arabic skills?
Yes, it's an ongoing frustration that my brain has not been able to absorb the many lessons that I've had in Arabic. Yes, absolutely. And that's another issue why I suppose for me the licensing...
that KIMS, as a director of KIMS, always I remind faculty that we have a courses. And
I audited a wonderful course, and then it was in... I think it must have been 2019, fall of 2019, so it fell apart. So I've been to Egypt, I've been in Palestine, and been to classes, even in Northern Ireland when I knew I was going to Palestine, I had classes by a Moroccan teacher, so I've had some input. And I understand a fair bit, but I would love to be at the level where I could work in Arabic professionally. And that's also why for me the licensing is less of an issue, because I would want to be able to speak in Arabic in order to doing therapeutic work in somebody else, in the patient's second language is not fair.
But you are lucky that you are French and British, so you're I mean, in Lebanon, if you know French also, I mean, you have access a huge chunk of Lebanese, I mean,
and for many people it's also their first language, so it's or a joint first language. So
this is why Lebanon is not the best country to learn.
No, it's the worst country to learn. Everybody speaks 3 or 4 languages.
You know, I mean, and French Cultural Center, they have a very successful actually in IFPO, in Institut Français de Proche-Orient, Arabic lessons that they for foreigner, and because Syria is really not much people speak English or French.
Syria was always the place to go. For Arabic.
So I hope will come again place to go.
And I've loved Arabic since I was 18. I went to university and met Arabic speakers, and I've always been interested in Arabic. So it's not something recent, not since I arrived in Lebanon. It's been many years. I'm on my bucket list.
So translation of some your article. Are you eager? Are you
very eager? Yes, and I've realized recently, like some of the mechanisms, because the publications are so English orientated, to have like we've just included supplementary material of the materials in Arabic. So that it's still hard to access, though. I mean, it's available online, but someone would have to have good enough English to find it. So that's frustrating. We try to disseminate through summaries that we give to the community that we've been working with, and to disseminate it that way, to have workshops, to speak to the partner organizations, to find other ways than publications to disseminate information.
In any case, I mean, the fact that always you work on a big team, so I think that you will have a multilingual researcher,
and we always partner with organizations that are working closely with the target population. So there's always a link, and we also always have community advisory boards made up of our target population, and so we have links to the communities, and they also suggest, why don't you make a Facebook group, or why don't you do this to inform people about what's happening, because they won't access the publication.
But by the way, you work a lot with which War Child organization, and now I know they have a big project in Syria, so I'm so glad, because I think Syria with all the I will say the protracted trauma they have, 15 years of really like civil war. I don't like the word civil war, but and I think they are much needed such intervention.
And I've really enjoyed my work with War Child. I respect them very much. They have a vision for improving mental health services. They are very interested. I mean, this is how we ended up working together. They have a vision for family work, and they test what they're doing, and they use what evidence exists, rather than just what seems right, especially coming from outside in. So I very much respect the work that they do. So I'm glad, that they're also inputting in Syria.
Okay, so thank you so much, Tania.
Thank you. It's so
it was
interesting
really
to talk to you.
a pleasure to have this conversation with you, and so thank you for listening to us, and hopefully to see you in another episode of our podcast series, Connecting Social Research to Society.
Thank you.
Goodbye.